school, focusing really on surgery and periop care, so a lot of resident and med student education. My newest hat is I am our orthopedic chief at Dell Children's Medical Center, so a lot of admin stuff in addition to a lot of the clinical care. And I also work for Central Texas Pediatric Orthopedics. That is really my primary home. We'll talk about that in a minute. To get started, just going to give you guys an introduction of me. I grew up in the great state of New Jersey with our musical Jesus, Bruce Springsteen, up there. If you want to know, if you're from the East Coast, exit 172 on the Garden State Parkway. That's where I was from, so the very top. After high school, I went to Washington, D.C., where I did undergrad, med school, and residency at George Washington University. Very fortunate to be there and be in our nation's capital for almost 15 years. A lot of fun, made a lot of good friends, and met my lovely wife there. After residency, I went to the A.I. DuPont Hospital for Children in Wilmington, Delaware. And DuPont is a fabulous place to train with a lot of really wonderfully intelligent people who are kind enough to impart a lot of wisdom and knowledge to me. And then, like everybody else, we moved to Texas in 2016 to join CTPO. And I guess the majority of my practice is on pediatric spine and pediatric spine deformity. So I treat a lot of spinal cord injuries and a lot of children with scoliosis and spine deformities after a brain injury, either traumatic or anoxic. So a large portion there. I do a lot of work with our neuromuscular patients as well. So I run our spina bifida clinic. I also just take care of a lot of our cerebral palsy population. So a lot of experience with kids with neuromuscular conditions. And fortunately, Dell is a wonderful place that some of you all have the good fortune of going there and being cared for there now with Maureen Smile, which is good. They do a nice job. So where you can find me, I'm running around all over town usually. So our main office is right by Dell Children's, the one on Barbara Jordan. The hospital is right across the street from us. We see patients there as well. We have an office in Cedar Park in North Austin. We've got one right down the road on Dynamite. So we're kind of all over the place, keeping me busy. So I think a lot of this stuff is stuff y'all probably know, but when I was kind of going through and getting ready for this talk, I thought I should kind of figure out how many kids have a brain injury in the first place. And our incidence of CP we'll talk about in a minute, or cerebral palsy, but traumatic brain injuries is not something that I had a huge experience with that I knew a lot about. So to hear that 450,000 children a year suffer a TBI is really, I guess, depressing, almost one word. Now, a lot of that is your kid who has like one minor concussion. Still a brain injury. We know there's a lot of effects that come down the road from that. But where I come in are those 35,000 kids who have a really severe brain injury who wind up at some point in my office for some sort of orthopedic complaint. We seem to think that age has a big determining factor on the etiology of your brain injury. So young kids are going to fall. I could fall from off a stage, like me, if I was not careful here, or just kind of off the couch, off the trampoline, off the monkey bars. That's our most common ones. For the kids that are a little bit older, between 5 and 14, you're still seeing falls as the most common cause. But then you start seeing things like sporting accidents and car accidents coming in. I think the reason that we don't see as many car accidents in children under 5 is that if your child is properly restrained, you have a much lower incidence of developing a brain injury. Our restraint systems are much, much better for children under 5. It's when you start getting kids into booster seats that don't quite fit right, that you're seeing more brain and spinal cord injuries in that population. Then over the age of 15, motor vehicle collisions are a number one cause of brain injury, a number one cause of spinal cord injury as well. There was a 2005 study that saw 145,000 children that had severe traumatic brain injuries, and they estimated the total cost of healthcare for those children over the course of their lifetimes to be about $60 billion. So clearly, this is a big problem, has a big financial and socioeconomic impact on all of us. So I just thought that was kind of a good review for me. Y'all probably know this stuff already. But a TBI is really part of the story. Like I said, a large portion of my patient population are the cerebral palsy population, and most of those children develop some form of static or non-progressive brain injury before the age of 2. That is our textbook definition of what cerebral palsy is. But there's really a lot of gray zone, and what I'm fond of saying to most of my patients is nobody fits in a box. So there's not really any definition for a kid that has CP. That doesn't mean that if your child has cerebral palsy, they're going to follow a set course of outcomes, or we can predict what's going to happen with your kid just because there's been some other kid that has CP. I don't think that really works. It doesn't fit for my patients, so I don't really practice that way. The incidence of CP hasn't really changed. It's been about 2.4 children per 1,000 live births over the last 30 or 40 years. Part of that, we think, is that while our neonatal or perinatal mortality rate is dropping, we're really good at keeping really premature babies alive longer. And there's a much higher incidence of developing cerebral palsy in a premature child. So if we're better at keeping those children alive, which is wonderful, they just have a higher rate of developing brain injury. So I think that's why the incidence has stayed relatively the same. The children that were getting anoxic brain injuries from more obstetric trauma that was more common in the 50s, 60s, and 70s, we weren't as good at monitoring people. Those numbers have gone down significantly, but we've kind of matched those and replaced those with children who, in the 50s, 60s, and 70s, were passing away. We weren't able to keep those really premature infants alive. So it's all kind of balances out to roughly the same incidence. We know there's a much higher incidence of cerebral palsy in multiple births, proportional to the number of children that are born. So the rate of CP compared to a single birth for twins, I think goes up about 15 to 20%. With triplets, it's up 35 to 40%. With quadruplets, it's up to 60 or 70%. So it gets really, really high really quickly. And just kind of think there's not a lot of space in there. There's less room for development, and the more multiples you have, the more likely those children are to be premature, so you get that double hit. And we think that the neonatal causes are from primarily intraventricular hemorrhages. Premature infants are at a much higher rate for developing intraventricular hemorrhage. If you have a grade 4 or a severe intraventricular hemorrhage, your rate of developing cerebral palsy is somewhere in the mid-70s, about 76%. So it's very high if you have a severe brain injury or severe brain bleed when you're born. There are children who develop CP as a result of a congenital cause. Those are often genetic mutations or some other developmental condition that develops while the child is in utero. We talked about our neonatal causes and postnatal, typically thinking in that first 6 months to a year of life afterwards. The unfortunate vast majority of those children develop CP as a result of non-accidental trauma or child abuse. So non-accidental trauma is our doctor word for it, but child abuse. So why you need me? Any kid that has a brain injury or has a spinal cord injury or has CP, you're going to realize quickly that your brain affects your muscles and your bones. So spasticity is by far and away our biggest issue that we address in the office, but we also see kids with dystonia, flaccidity, or hypotonicity, and ataxia as well. Now, I am very fortunate that I work with a wonderful neurologist most of the time. His name is Jimmy Ong. Jimmy is an awesome guy who's really smart, and in the world of people who take care of children with CP, Jimmy is a rarity. He is truly a pediatric trained neurologist who devotes his entire care to the neuromuscular cerebral palsy population. The majority of times you're finding a physical medicine rehab or a PM&R doc who does that. So Jimmy brings a very different perspective, and we're fortunate enough that 2 or 3 times a month we do a clinic together, and we kind of go bounce ideas off each other all the time. So he's a great guy. Where your tone and spasticity particularly affects you in my office is gait, seating tolerance, activities of daily living, bracing concerns, and we know that if we're able to manage spastic tone effectively, it really improves quality of life. There's certainly a large caloric expenditure for high spasticity, so it can be difficult for a very, very severe spastic child to keep weight on because they're constantly firing their muscles. Just kind of think, if you sat there and tried to flex your biceps for 15, 20 seconds and just held it like that, you're going to start feeling it, you're going to start getting a little burned. Now imagine if you couldn't stop. It was just like that all the time, constantly. So that burns energy, and that's why those kids have a high caloric intake and it's hard for them to keep weight on. So if we can do something to manage that tone through medications, through injections, through surgery, it has a big impact on quality of life. Dr. Ong comes in, he does most of our Botox injections, so he helps with that medical management. Botox does have a potentiating effect or effect that decreases over time, so then eventually when your Botox stops working, you wind up in my office and talk about surgery, but I like to know you well before that, so we're kind of building that relationship along the way. I think, like I said, I am incredibly fortunate to work at Dell. It's a wonderful hospital. We have a wonderful team of people who are physical therapists, or orthotists, our social workers, our nurse practitioners, and all the other surgical and medical subspecialists who work with me that allow us to provide a really comprehensive care to our children. It's a really wonderful resource. The Specialty Care Center is named after Marnie Paul. I've had the good fortune of meeting Marnie a couple times. So Marnie is now an adult with cerebral palsy, and her family, I'm pretty sure her dad started, I think, Golf Galaxy. I think that's his. You can go back to wherever I was before, man. I don't know what, as you promised, told me not to hit a button, I hit a button that I wasn't supposed to. So, we keep going backwards. Keep going backwards, keep going. Perfect. Anyway, surgery is the last resort. So even though I'm an orthopedic surgeon and surgeon is part of my title and my part of the end of it, I don't want surgery to be a first resort for anybody. Surgery is a last resort. It's something you get to when you've exhausted all your other options. And we should have a way to avoid surgery or limit the amount of surgery we do as much as possible, which is why I want to know you early. I want to know your kid right after their injury, whether that's 6 months after they're born or 6 months after they have whatever the traumatic brain injury is. The earlier I know something, the quicker, or the earlier we can intervene, the less likely we are to have to do something major in terms of surgery. A great example is hips. So if you think about hip disease in children with cerebral palsy, it's incredibly common. So especially the more severely affected you are, kids with severe CP, what we call the GMFCS, or Gross Motor Functional Classification Scheme 5, those children have probably a 60 to 70% rate of developing hip subluxation or hip dislocation. If we know about that earlier and we can affect the hips before they dislocate, it's much easier. You still may wind up with a relatively major surgery, but that relatively major surgery of reconstructing and putting those hips back into the joint, the difference in waiting till they're out and the kid is 10 or 11 is 5 or 6 hours of surgery or an hour and a half of surgery. And going home maybe in a day or two versus going home in a week or a week and a half. You'll get to the same place eventually either way, but it's certainly a lot easier if we can do surgery relatively earlier. And we're pretty good about kind of walking out through that. We don't want to push surgery, but especially in the hips, it's really hard to kind of tell people when your kid is having no pain and they feel fine and we're going to do this big crazy surgery on it. But it works, I promise. So before we can really talk about how I'm going to treat scoliosis or how we approach treating it non-operatively or operatively, you should probably know what it is. So scoliosis is really a three-dimensional deformity of the spine. So sorry, these are all overlaid over each other. The deformity occurs in 3 different planes. So you have a frontal plane deformity or a coronal plane deformity. That's what you see on the Xray where you have an S shape or a C shape to your spine. That's really easy. Everybody can understand that. Fortunately, that's what we use to guide our treatment as well. So the degree of your curvature, your Cobb angle, that is what dictates our treatment for the most part. We use it as a substitute for the other ways that we see the spine curve. So from the side, the spine typically flattens in your idiopathic, otherwise perfectly healthy kid who has scoliosis. So that's not always the case in a neuromuscular scoliosis. You can have a neuromuscular curve that is severely flattened from the side, or you can have one that develops a lot of kyphosis or bending forward. In particular, the kyphosis, once it gets over somewhere around 90 degrees, or if your curve from the front gets over 80 to 90 degrees, your risk of having organ dysfunction in terms of pulmonary compromise or cardiac compromise starts going up. Your organs are not really affected until that point. However, we don't want to wait until we get there to fix it. It just makes things a little harder. So we know that once your curve gets that big, it's going to have that effect on you, but we don't have to let it get there. And then the rotational component is the last component. That's what everybody sees if you've got your kid going to the school nurse, bending over and touching their toes. Do you have your scoliosis screen? That what we're looking for is the ribs sticking up on the outside or the convexity of your curve. Your ribs are attached to your spine. If your spine is curving, it is also rotating or twisting, so the ribs on the outside will stick up, so they'll be the high side. Your typical scoliosis in your healthy kid is a curve that goes to the right in the thoracic spine, the portion of your spine that's connected to your ribs. So kid bends over, ribs are up, that's scoliosis. That rib deformity can have a big impact on our wheelchair-bound patients because it can make it difficult to fit a molded back to the chair if you have a big rib deformity that's sticking out and pushing you forward. Also affects the balance of your spine from the side, which has a big impact on seating as well. So hyperkyphosis is where that spine is bending more forward. The X-ray on the left is a young lady with, I'm going to blank on the name of her very rare genetic condition that she has, but she essentially is a fully involved cerebral palsy kid. From my perspective, as just a simple bone doctor, but she had about 85 degrees of kyphosis at her thoracolumbar junction, the portion of your spine where your thoracic spine meets your lumbar spine. That portion of your spine is normally perfectly straight. So you should have no bend there at all. Now, if you can imagine that girl when she's trying to sit in her chair has a big bump that's sticking out in the middle of her back. So it's very difficult for her parents to keep her upright. She had a lot of restraint across her chest and under her chin to keep her from pitching forward because of how much curvature there was on the side. This isn't as big of an issue in children who we're not wheelchair bound. So your kid is walking around, okay, you've got a little bit of a hump in your back, it's not a big deal. But for her, big deal, big problem. And after surgery, we were able to really correct that deformity and pull her back so nicely. That's the thing that Her dad noticed right away too. He said, I don't really care about the other X-ray from the front, I really care about the X-ray from the side. And he was very right to say that. As a surgeon, the way I judge myself and I judge my peers, I care way more about what your X-ray from the side looks like. It's much harder to do than make your X-ray from the front look straighter. X-ray on the right is a fully involved child with cerebral palsy who had surgery this spring. He is hyperlordotic, so the bottom of his spine is very, very swayed, which from my perspective is very difficult to treat because it's hard to pull that spine out. But what happens when you're hyperlordotic, it causes your pelvis to rotate farther forward, you put more pressure on your ischium, the bone at the bottom of your pelvis, can right under your butt cheek, which can make it harder to sit, and that can cause pressure sores. So you really want to try to balance the spine from the side. And don't forget about the pelvis. I think the thing that I harp on the most with people when we're having a preoperative visit is talking about what we call the obliquity or the angle of your pelvis. So Jenny is not here because Jenny already went through all this, but if you all know Jenny Sears, her son Ben, this is Ben's X-ray from earlier this summer. So that line, so the diaphragm pump is up and we'll look at the right circle. The line at the bottom that is about 40 degrees off of axis, not the 95-degree curve, the other one where it says 129 at the bottom. So that number should be 90. So what we're looking at there is drawing a line across the top of his pelvis, across the wings of his ilium, and then drawing a line straight up toward the ceiling. So when Ben is sitting, or when Ben was sitting, all of his weight is on his left side. On that X-ray, left is left and right is right. So all of his weight is on his left hip. You can imagine if you all just sit there right now, try to put all your weight on one butt cheek, pick your other leg up, then kind of spin your body like this. If you can make it more than 30 seconds to a minute, you're better than me. It's really uncomfortable to sit that way. As that pelvic obliquity gets more and more in response to your bigger curve, the ribs that are on the side of the pelvis that are high are going to start hitting the top of your pelvis. Called that costopelvic impingement. What you can imagine is that wing of the pelvis is driving into the bottom of your rib cage. It's not comfortable. It's a very difficult way to sit. What we find with those children is that they often, at that point, start having feeding intolerance. There is no definitive medical evidence from our literature that shows that there's an improvement in feeding or weight gain after scoliosis surgery. It is totally anecdotal. It definitely works from my end. From my perspective, children like Ben or CP kids who level their pelvis definitely do much better with the eating tolerance after surgery. And there was a study that looked at pressure mapping of a wheelchair before and after surgery compared to how much pelvic obliquity there was. At only 12 degrees of obliquity, there's already significantly different pressures on the ischiums, which can lead to pressure sores and just more difficulty having a well-balanced chair. So my goal with surgery is under 10 degrees. We know that from long-term outcome studies looking at quality of life, if we get the pelvis under 10 degrees, seating tolerance goes up markedly. So the ability for the child to sit upright for a longer period of time is higher if we're able to get the pelvis really level. So that was not very easy. Ben made us work pretty hard for it, but I'm very happy that we went from 40 degrees of obliquity down to 5 degrees. Now, the spine is still crooked, right? The spine isn't perfectly straight. I almost say who cares? I will sit there and cover up the rest of his X-ray because you can't see it in him. What you see is that he sits up straight, and he's not sitting there with his ribs going, sticking to his pelvis. We could work really, really hard and try to get his spine perfectly straight on an X-ray. We could do things like take away more and more bone from the spine, do what's called a vertebral column resection. We actually take an entire vertebra and the portion that surrounds the spinal cord out so that your entire spine is very flexible and can move it wherever you want. It is a very risky procedure with a very low benefit other than making your X-ray look pretty. So my goal is to not do that, but to loosen the spine enough that we can pull your pelvis down. We do that by different medications through surgery. We release muscles. We've done traction before where we put weight hanging on one leg. So for Ben's surgery, his right leg had a pin in it, and we had weights hanging off the bottom of the bed. So we were pulling on his right side the entire time, gradually stretching his muscles and tendons down so that we were able to push him down that much. Why your kid gets scoliosis? I don't know. I think the best answer and the best honest answer I can give you is we don't know. We don't know why children with brain injuries get scoliosis. We know they do. We know the rate is incredibly high, but why? I don't know. Unfortunately, the more severe your brain injury is, the more likely you are to develop a curve. If you go back to those cerebral palsy kids, the ones who have a severe or severely affected with their cerebral palsy, grade 5 kids, has a 76% chance of developing scoliosis. About 60% of those kids will wind up needing surgery. So it's not everyone that needs surgery, but the rate is very, very high. If your child is ambulatory, the rate of scoliosis goes down markedly, pretty close to the general population's level, people who don't have a brain injury. But keeping kids walking is wonderful. It definitely has a good effect on the spine. I think, on my totally, mildly expert level opinion, that it just comes from muscle imbalance, and I'll talk about that on the next slide. But we know that, again, the more severely affected you are. So this kid is a really interesting family. The mom's really nice. We've known each other for a long time now. So he's a near drowning child who had a traumatic brain injury at the age of about 2. The Xray on the left, he is 4 years old. So probably can't see the number on there, but it's 97 degrees. So he has a 97-degree scoliosis at the age of 4. It seems that the kids after the age of 2 who develop a brain injury are much more likely to have a very rapidly progressive scoliosis. We'll talk about that in a minute as well. So he's one of those kids who wasn't born with a brain injury, was born healthy, had a brain injury, then get a very rapidly progressive, very severe curve. Just like our last X-ray, you can imagine how oblique his pelvis is. Now my challenge is he's 4 years old, so I can't do what we did on the last slide. We can't put rods and screws and fuse the spine in because he's going to be about this big. So what we did is put a growing construct in. So these are called magic rods, M-A-G-E-C. I forget what it stands for, but it's a magnetically controlled growing rod. So those kind of wider portions in the center of his rods, where it looks like it's a little bit thicker, that is a magnet with what's called a Wormian gear. So it is a screw that responds to a large magnet that is placed over the spine. The magnet turns in some way, like an MRI does. It causes the screw to spin inside of the rods, and the 2 rods get pushed apart. So in our office, every 2 to 3 months, he lays on the table, take a big magnet, put it on his back, press a button, and he gets a few millimeters taller. So we just do that every few months. And eventually, he's going to run out of room. Those rods are going to run out. But my goal is to try to time it that we're going to get him to 8 or 9 years old, and then we can do his one final surgery. But we couldn't leave him 100-degree curve for 6 or 7 years. That wasn't going well. He was already having trouble sitting up at all. He was primarily laying down all the time. His wheelchair will recline very heavily. Now he sits up, he's very happy, and we just did his hip surgery a couple of weeks ago, or a couple months ago now. So he's really doing much better. I showed his X-ray at a conference I go to every year with a bunch of pediatric spine surgeons, and Michelle Wellborn, who's one of my friends from the Shriners Hospital in Portland, Oregon, said, "Oh, Brian, it's really great. If you can make it for to him to maturity to get a spinal surgery without operating on him again, I'll buy you a beer." So Michelle, we're 2.5 years in, we're doing okay. He is doing just fine. And the hard part is in young kids, getting those screws that are in there to stay stable. So he's got 6 screws at the bottom and 6 screws at the top. Now, that's more than we normally do. We usually do 6 at the top and 4 at the bottom. But again, I was worried about it. We had to put a lot of force on him. Small bone, small screw, lots of force. So over time, those screws can loosen, can pull out. Like he's done great for 2.5 years, but 2 years from now, one of those screws could break, one of those rods could break, and then he's going to wind up having another major surgery. So this is a great option, but it's not the be-all and end-all for kids who are growing. Spinal cord injury is very different. I know why you get scoliosis after spinal cord injury, or at least we know that the rate is incredibly high. If your child has more than 1 year of growth remaining after a spinal cord injury, the incidence of developing scoliosis is nearly 100%. Randy Betts, who is an older spine surgeon who used to work in the Shriners in Philadelphia, he devoted a large portion of the first part of his career to treating children with spinal cord injuries. So from the orthopedic literature, most of our epidemiological work comes from Randy's work. He's an awesome guy who I'll get to see next week too, which is fun for me. So Randy told us that we know if your kid is still growing, you're going to get scoliosis. Randy thinks that it's because of just general hypotonia that you get when you don't have trunk control. And what can happen is that as your spine is growing, you have this muscle imbalance. So you're relatively hypotonic in a spinal cord injury patient. From what's called the Heuter-Volkmann principle, so German guys, bone grows in response to stress. So if you are relatively imbalanced, and for whatever reason, either from hypotonia or from spasticity, it's more on one side or another, and you start leaning a little bit to one side, what will happen is the growth plates in your spine on the outside, on the convexity of your curve, will start growing more rapidly than the ones that are under compression on the inside or on the concavity of your curve. So then you should start going more and more with scoliosis. Now that would be great and it sounds really simple, but it's not 100% accurate. Because if that was the case, we could put every kid with a spinal cord injury or with cerebral palsy who has a risk of developing scoliosis in a rigid scoliosis brace and they wouldn't develop scoliosis. It doesn't work, so that's just, we don't completely understand it. I think that on a basic level makes sense to me, and that's sort of how I think about it, but it's not 100% correct. And I will be very honest and admit that to you, that that's not true. We've thought that for years. I found a picture of Google Images basically describing that, so that tells you how common it is. So you see wedging. The question is, do you see the difference? You see wedging of the disc spaces on the X-ray, and then you can't really see the growth plates on your vertebral bodies on an X-ray. But if you do an MRI, you'll see that there's more. I guess the growth plate on the outside will light up a little bit more than the one on the inside will. But again, it's a very imperfect process because you'll have two kids who have the same spinal cord injury who one develops scoliosis and one doesn't, and why I don't know. So again, we don't completely know, but that just sort of at a basic level to me makes sense. Evaluating for scoliosis, you can't see scoliosis on an X-ray. So the people I have the most challenged with are my muscular dystrophy population. So in keeping with the, Brian sees also the weird stuff in our practice. So I take care of all our muscular dystrophy kids as well. For whatever reason, in our area, I can't get the medical docs who take care of our muscular dystrophy kids to get an X-ray of them or send them to me. So we get the kind of clinical check of, oh, your kid's back isn't curving. Well, I mean, if you've got a really skinny kid, it's pretty easy to see if their spine is curving or not. But you know, if your kid has any sort of normal weight on them, you can't see that curve until it's 50, 60 degrees. And well, the ship's kind of sailed at that point. So you can't see it if you don't have an X-ray. X-rays are easy to get. They're cheap. They work really well. We only need one about every 6 months, and that's while your child is growing. So once you get to 13, 14, 15 years old-ish, depending on if you're male or female or your genetic background, growth plates in your hand that we use to count for growth plates in your spine, substitute for growth plates in your spine, X-ray every 6 months is sufficient. Dell has a low-dose X-ray machine called an EOS. The radiation that you get from a traditional X-ray, the one that you print out on paper, that machine is about 100 times less radiation than one of those printed out X-rays. What you would all get now, nobody does that anymore, so you get a digital X-ray now, where you go and take a picture and there's a big cassette film that goes onto the computer. The EOS machine is about 7 times less radiation than that. So it's still a big reduction in radiation. The nice thing about the EOS is that you can sit in this little chair, so if kids in a wheelchair, they can still use the EOS machine. And we get 2 pictures at the same time. It takes about 30 seconds. I like those pictures better. I think they're better quality than the traditional X-rays we get, so they're very effective. If you're going to get an X-ray somewhere else, you have to make sure that your kid is sitting upright. A supine or laying down X-ray doesn't help me a lot. Your kid isn't laying down all the time, they're sitting up all the time, so I want to know what gravity does to their spine. You want to make sure it's on a 3-foot cassette, so we want a long cassette so you can see the whole spine at once. We want the films to be stitched together, so a digital X-ray where they will take, usually if you've got one of those 3-foot cassettes, it's 2 X-ray plates, and then the computer stitches them together. You want X-rays from the front and from the side. And I would say, I'm going to go for a solid 75 to 80% of the kids that get referred to me for scoliosis, we re-image again because their initial X-rays are inadequate. It's inadequate for me to make a decision, which doesn't really help. I don't like exposing your kid to more radiation, but I want to be able to get a good X-ray in the first place. We've got lots of families who live all over the place. We treat kids from 54 counties in Texas, so I've got people that are 7 or 8 hours away that come for appointments. So sometimes they want to get their X-ray before. I write them about a 5-sentence long prescription if they're going to get an X-ray somewhere else of all the things they need. It's just very specific, and there aren't a lot of places that will do those X-rays. So if you're going to get an X-ray somewhere, call and ask first if they will do it. You just save your kid another X-ray. If you're coming to see me or really any other pediatric spine surgeon, they're going to have X-ray facilities in their office. As pediatric surgeons, we're used to kids in wheelchairs. We've got Hoyer lifts in our office and big strong people who can help move people around. We're used to it. Let us take the X-ray. You'll get one X-ray, you'll be good to go. So you can, the pictures are overlap here, but right in the middle of those two is the kid taking his EOS X-ray. I'm sorry I can't say that, but it's good. Non-operative treatment. So this girl obviously doesn't have a brain injury despite her face, but this is my favorite scoliosis brace X-ray. I use this for every talk when I talk about bracing because you can see how thrilled that girl is to be in that brace. She is absolutely loving it. That's really the problem with bracing. So we know in our healthy, non-brain injury population, bracing works. Bracing definitively works to prevent the progression of scoliosis. It has been studied ad nauseum. There's a big paper in the New England Journal of Medicine from 2014 where they looked at thousands of patients and treated them with braces. Bracing works in kids who don't have a brain injury. Nobody really knows if it works in the brain injury kids. If you go back to the beginning, nobody fits in a box. So if nobody fits in the box, it's hard to match people together to do a big research study. It's also really hard to get most kids with some kind of brain injury or other underlying condition to wear a brace consistently. They are very used to things like heating intolerance and skin intolerance, or just the feeling of having something really tightly compressed around you. Your kids probably won't tolerate that. So it's hard to get somebody to wear a brace for the 12 to 16 hours a day that I want to see that there may or may not be benefit. I put kids with cerebral palsy and brain injuries in braces all the time, but I have this discussion with families coming in that I don't know if it's going to work or not, but we can try. We can try. At the worst, it may, or the best, it's going to delay that curve from getting bigger. So you don't want to wind up like that kid who had the growing rod spin. If we have a kid who is 5 or 6 years old with CP who has a 35 or 40 degree curve, we put him in a brace and get him to go to 10 or 11 years old, and it's gradually, slowly creeping up. That is a huge win. Then we can do one operation, and the kid's spine is protected for the rest of their life. Fingers crossed there. One operation. So that's where I like bracing. We use a lot of different kinds of braces. Most braces are named after the place where they were developed. So you've got Boston braces, you've got Charleston braces, Wilmington braces, Providence braces. We don't have an Austin brace yet. Give Dr. Murdoch, my partner, some time. He's working on it. So for your brain injury kid, you're going to use some variant of a Boston brace or a TLSO style brace. It's a hard plastic clamshell that opens in the front with Velcro straps that pushes on your kid to hold their spine straighter. There are lots of variants you can do. So we've got some lovely orthotists who do what we call half soft TLSOs. So the back is rigid plastic, the front is like really thick foam. They're a little bit better tolerated. It's not as rigid, but again, we're just trying to delay. We're trying to hold things. We're not trying to correct the curve. Those work pretty well. So I think if someone's advising you to put your kid in a brace, just know for scoliosis, there's no definitive evidence that brace will prevent your kid from developing a curve. It may slow it down, especially in the spinal cord injury population. It may slow it down. There's some thought that we should be bracing spinal cord injury kids when they develop a curve of 10 degrees or more. Typically, we're bracing kids that are 25 or 30 degrees, but 10 degrees in the spinal cord injury patient, especially if they're under the age of 10. I think it's a lot to ask a kid to wear a brace all the time. I use 20 degrees as my cutoff for a spinal cord injury kid, but again, nobody really knows the right answer. So should you try to wear a brace? Depends what your goals are. It depends on what kind of brace you're going to use. So the XDEP brace is a spine core brace. So spine core is a soft bracing strap system. I don't see it that often in our neuromuscular kids, but in our idiopathic kids we see it frequently. We do not like the spine core brace. Most pediatric spine surgeons do not like the spine core brace because it doesn't work. So don't use one. But soft bracing does have a role. So that brace on the left is a TheraSuit. So a TheraSuit is really well named. I like how they named it and called it a TheraSuit. It's not a brace to prevent scoliosis, right? This is a therapy assistive device. So that's a spine brace, but I write for TheraSuits all the time. I think they're great. But it's not going to prevent your scoliosis, but if it gets your kid upright, helps them do weight bear, helps them move around, it's fantastic. I'm all about it. That sounds fantastic to me. What doesn't work? So e-stim therapy, one of my mentors, a guy named Freeman Miller, who's done probably all of the work, or a lot of the work on our knowledge of treating children with cerebral palsy. So Freeman's an awesome guy who is actually ex-Amish, very interesting life, great background story. Google Freeman Miller, pretty fascinating guy. So Freeman did a study looking at e-stim therapy in children with cerebral palsy with scoliosis, and would the e-stim alone prevent the scoliosis from developing? The answer was no. He pretty definitively proved that. That's not to say there isn't a benefit to stim therapy for different things. Do not use it for scoliosis prevention alone. You can use it for anything else you want, but don't rely on the stim to be the thing that prevents your child from developing scoliosis. And the same goes to chiropractic care. So there is a benefit to chiropractic. I would say people believe there's a benefit to chiropractic care for pain relief and everything else. It does not work to prevent scoliosis. I have a very strong opinion on chiropractic care. I'm happy to tell you that later. but it doesn't work for scoliosis to prevent the curve from progressing itself. So you can use it, it's fine, but if your kid's in a brace or you're doing anything else, keep doing those other things because the spinal manipulation itself is not going to prevent the curve from developing. So now we're kind of at our last resort, right? Our surgical treatment. So cited, this is not mine. There's fun pictures behind her of this girl before after surgery, and I didn't have any good clinical pictures. But she looks miserable in the picture on the left, and she's smiling happy in the picture on the right. But this is sort of your extreme case. Most of our cases are not this large for a curve. So our threshold for surgery is 50 degrees usually, but not always. There's no, you never have to do spine surgery. This is an elective surgery that you enter into a decision to do with your surgeon and after you discuss it with your family and anybody else. Nobody has to have spine surgery. There's a lot of benefits to it, but keep that in mind. Don't let anybody push you into doing it if you're not comfortable. But it's probably the most impactful surgery I do from a quality of life perspective. We know that if we balance someone's spine, and most importantly, if we balance their pelvis, that their quality of life is going to go up. We can measure the child's quality of life or the caregiver's quality of life with validated outcome tools, and there is a definitive benefit to balancing the spine and balancing the pelvis with surgery. So it works. It's a big surgery. It's an outbalance risks. And there are ways to how it's done. We'll talk about how you can do it effectively. So this is one of my patients. So this is a kid with cerebral palsy who developed progressive scoliosis. I've got an 80-degree curve on the top there, and it's 81 degrees on the bottom. He was 18, I think, when he had his surgery. This is 2 summers ago now. My fun story about him is that he got 2.5 or 3 inches taller after surgery. So parents come back for the first post-operative visit. He was in the hospital for 2 or 3 days. He went home. He did great. He's off his pain medicine 2 weeks after surgery. I said, how are you going? You guys happy so far? And his mom said, I'm happy with one thing. I have to buy a new car. I said, what do you mean you have to buy a new car? Apparently, I made him too tall for his car. He's a big kid. He's probably about 6'3". So he was about 6 feet before surgery. He fit fine in a wheelchair van. Now, because he wants to sit up straight and look out the window and see what's going on, he can't do that because his head hits the ceiling. So we had a good laugh about that. But now I tell people, like, if your kid happens to be around 6 feet tall before surgery, just keep that in mind. So the way surgery is done, typically we're doing 1 incision in the middle of the back. There are situations where we will go through the front of the spine to loosen things up. That's really in your very severe scoliosis. We're talking like 110, 120 degrees where we need to get more movement in the spine. Up to like 95 degrees, we're probably fine just going 1 incision down the middle of your back. We move the muscles out of the way. Then we put screws and rods in. My preference is to use a navigated screw placement. So we use an intraoperative CAT scan. Big machine comes in, takes a CAT scan of your kid. Then we use a computer program to give us real-time look at how we're putting the screws into the spine. So I hold an instrument that has little radio frequency balls on it. It's picked up by a camera that's at the foot of the bed. The CT scan is projected on the screen, and then that instrument projects onto that CT scan. So as I move the instrument around, I will see where it's going to go in the spine. That system is accurate up to less than 1 millimeter, so it's incredibly accurate, which makes my job a lot safer. I don't want to say easier, it's definitely safer though. Sometimes we're putting screws in spots that are really, really tiny. You might have a pedicle or the section of your spine that you're putting a screw in that is 2 or 3 millimeters in diameter or width. You got 1 shot to put that screw in. Now, it's not a huge deal if you miss in the sense that you can't put a screw at that level, but if I can get more screws in, the more stable we can make it, that's going to be less likely to need something else done down the road, or for rods to break or screws to break, or it gives me more power to be able to push and pull on that spine to balance things out. So it's a very, very powerful tool. It's been well shown to improve safety, so I'm a big fan of it. And Dell was nice enough to buy us one of those a couple of years ago. In general, we're pretty good about getting our kids out of the hospital between 3 and 5 days. That is a very general statement. There's so many other factors that go into that, and we'll talk about those in a minute. As far as care afterwards, treat your kid like you normally do right after surgery. They've got a skin incision that needs to heal. That's all you have to worry about. I let my kids who are otherwise running around playing sports go back to sports as soon as they feel ready after surgery. So if you have a 14-year-old, I'll tell you about my friend Emily from the summer. So Emily, super healthy girl, cheerleader, does tons of dance, had a 55, 60-degree curve in her back. surgery this summer. She went home the second day after surgery. She probably got home the day after surgery. She went to summer camp for 3 weeks, Sleepaway summer camp 2 weeks after surgery. I saw her 6 weeks after surgery. She did a back bend in the office. So, you can get back. Those kids get back quickly. Your kid is no different. So in my mind, if you're going to use a Hoyer lift, or if you're going to pick them up, or you're going to move them around, or let them roll around on the floor, get them a stander, you can do that as soon as their skin is healed about 2 weeks after surgery. I don't have restrictions on activities. Things are going to go okay. It takes about 6 to 12 months for your spine to fuse. The goal of this surgery is to get your spine to fuse. Ideally, those rods and screws become obsolete after the spine is fused completely. You don't go back and take them out because it's a big surgery, but you theoretically could take them out. Sometimes we've taken them out for infection or for other concerns, and most of those kids have done pretty well and stayed pretty stable without the rods and screws in there. So there are people who talk about doing minimally invasive spine surgery for scoliosis. I would be very hesitant to have my child, if they had a brain injury, go through that procedure. The whole goal of surgery is to fuse the spine. I can only do that if I can look at the spine directly, get the bones to heal, to stimulate them to heal, and put a lot of bone graft down. We put a lot of material in there to get the spine to heal and to fuse. You can't really see a fusion for the most part on X-ray. It's hard, but if you get a CT scan, you see a big sheet of bone that rolls down the whole back after surgery. If, God forbid, you're operating on somebody's back for an infection or something else after kids had a fusion, there's usually a big giant block of bone that's there. It's very, very solid, very thick, and hard to get through. So the spine should fuse really well. And how to do it successfully. So this X-ray is the same girl that I showed you with all that kyphosis from beforehand. So I just flipped her X-ray around so that pre and post-op X-ray are the same. You can see how much smaller the bump is in her back, and she has that more normal S shape to her spine, that rounding her upper back and swaying the lower back. So how do you have success? Gather the troops. What we like to do at Dell, we started doing a preoperative spine clinic. So if you have a medically complex child, we want your kid to come in 3 or 4 months before surgery. We get everybody who's going to be involved in their care there. We gather notes from people. We ideally ask primary care doctors to come or to call in. Then we have our pediatricians who are going to manage your kid in the hospital there. We have an ICU doctor there. We usually have an anesthesiologist there. Sometimes we get physical therapists. We get OR staff. We get the implant reps, the people who are selling the hospital, the rods and screws. They're there for a reason, to make sure we have all the equipment that we need in the room. We all sit down in a big room around a big table and talk about each kid. We did this for 2 kids yesterday, so it's something that we do all the time. The idea is that everybody knows the plan and the steps for success going into surgery. The more prepared we are for any eventuality, the less likely your surgery is going to take longer, the less likely you are to have a complication. The faster we get the surgery done, the lower the risk of infection and every other complication. So we're really, really good about doing that. If you're going to have your child have surgery, ask. Ask if they do those kind of things. Ask how many surgeries they do a year. It's fine. If your surgeon's honest, they should tell you. I will tell you how many spine surgeries they do a year. Last year I did 48. So 48 pediatric spine fusions. That includes the healthy kids and the neuromuscular kids. It does not count the trauma kids. We had a rash of spine fractures last year. I did about 12 spine fractures last year. It's super uncommon. It's usually like 1 or 2 a year. But somebody should tell you that. In general, our societies consider someone who does 26 surgeries a year to be a high-volume spine surgeon. So you want to go to a high-volume spine center. I'm not a huge fan of somebody who does 2 or 3 of these a day in the same day, especially for a more medically complex kid. 1 surgery a day, 1 kid, just focus on that, do it well, go home, everybody's gonna be happy. And you want to know the rest of the surgical team as well. So at Dell, you have a preoperative visit where you meet the anesthesiologist, meet the nursing staff. We have a nurse coordinator. Her name is Bryce. Bryce is my favorite person on the planet. Her entire job is to make your experience better. You want somebody like that. So Bryce's job is to call you on the phone, send you text messages. If you have questions or concerns about something, she's your ear that you can grab on the weekends at night. What she does, she's very, very good at it. You want an anesthesiologist who does pediatric spine deformity all the time. If your kid has a heart condition, you want a cardiac anesthesiologist. If they have pulmonary problems, you want to have a pulmonologist crew in before surgery. You want to know everything you can going in. The more we know, the more likely we are to be successful. My job that day of surgery is to be the captain of the ship. There are 2 ways that you can run an operating room. I was taught in residency that I should yell at everybody and I should be really mean to everyone and assume that everyone is out to get me. It's a very tiring, exhausting way to go through life. We do not do that. I've taken a lot of time. We spend a lot of time outside of the OR with our operating room staff, We all know each other, we're all friends. So I know that everybody who's working with me knows what they're doing, and they have a job, and we're all going to do our job. My job is to do that. It is not my job to give anesthesia. It's not my job to monitor the spinal cord. It's not my job to be the nurse in the room. It's not my job to open the implants. I can't do all those things. If I'm doing all those things, I'm not doing that well. So you want a team that works together, that knows each other, and we are very much a first-name basis. I do not like being called Dr. Kaufman in the operating room. I'm still trying, but I prefer everybody to call me Brian. It's fine with me. I call everybody else by their first name. And then don't be afraid to ask questions. You should be your kid's advocate. I get a lot of flack from Bryce because she comes to all our pre-operative visits. She hears me say all the time, you're not allowed to have questions the morning of surgery. So you can be nervous. You're a parent. It's your job to be nervous. Your kid's having a big spine surgery. You're not allowed to have questions. You should have every question answered before that day. If you have to call me, my record holder mom has 12 phone calls before surgery. That's fine. 3 visits and 12 phone calls, that's totally fine. Because that morning, they had no questions. I would rather be in that situation. We all feel good about it. Part of my job is to educate you. If you're going to be a good physician, you should be an educator as well. So to educate you means that you have to be able to answer all those questions. And there are no stupid questions. At this point, I've probably heard every question you can come up with, so it's fine. Ask. And then also ask if you can talk to somebody else who's had surgery. Again, I'm an open book. You want to talk to one of my patients who's had surgery? Go right ahead. I'll give you a list of 10 to 15 names of people who will call and will tell you the good, bad, and the ugly. I send people to my patients who've had infections, who've had spinal cord or who've had nerve injuries that have fortunately recovered, knock on wood, who've had any kind of complication. Because my thought is, bad things can happen. We try really hard, but you should know that. And again, understand everything going in so you don't have a question. So in conclusion, brain injuries affect more kids than we probably think, or at least than I think. And severity of your brain injury correlates with your risk for scoliosis. Get an Xray every 6 months, get it upright, have it be a full-length film, preferably do a low-dose Xray if you can. Bracing is controversial, but it has a role. It leads to delay the need for surgery, and surgery, when done well, improves your quality of life. Thank you guys, appreciate it, and happy to take any questions right now.